extra pillow, kick the angle up if you need to. Pillow underneath their legs or in between their knees tends to be comfortable. You doing okay?
Yeah.
She's gonna fall asleep. So set up kind of the same as prone as far as you're addressing the head and neck and addressing the lower limb. And from there, you're looking for accessibility and patient comfort, okay? My recommendation is you get them as close as you possibly can. Techniques that help the patient feel comfortable with it are when you come up and show them where the barrier is. I'll often put my fist down here so that they kind of know, and I'm right at their hip. I'm trying to be cautious of modesty. So I'm right here, so Alondra, go ahead and scoot up a little bit more. Yeah, all the way up to me. I know, we gotta get close. Good, right. Okay, now she hopefully feels like she's not gonna fall off because I'm right here, and I'm gonna respect that I probably need to stay here now. Yeah? I'm gaining some trust with her like this. I could have done it at the beginning. I choose to do it right now normally to drape. Again, I'm gonna go past the waistband with this so that I can tuck the waistband back in one move, hopefully. I'll try to get the back and the side all at once. So I'm kind of tucking and exposing as much as I can right to the innominate, sacral base, PSIS, and all the above. So make sure you get a little bit of a tuck and a pull. I can put a second up here. I didn't grab one, but no, you can put a second up here. We tend not to tuck under the bra if we can avoid working with it. We try to, but that would be the best technique to lay this down and expose the other side. Cool, so this is our setup. Patient is close to our body, so we're not reaching. Supported legs are in between the knees, neck supported. Everybody feel clear with this? Hopefully those are easy points at this point, right? The next step, and probably the hardest step, is how do we assess the back by moving their limbs? So the idea is we're gonna take both hips into flexion, which puts the lumbar spine in what moment? Flexion, right? So CPA has a little bit of an extension component. This has a little bit of flexion. How many of you have treated parents in stenosis and you're like, they just love the shopping cart, right? So this might be a technique to help reinforce that movement. Fair? Now the assessment itself is going to be to isolate each segment. Got a good camera view, yep. Isolate each segment and feel the segmental movement. Okay, it takes so much practice and you kind of feel like you're making it up, but we want you to practice. Find the spinous, feel them separate. We hope you can appreciate just moving our hands like this probably isn't enough stress. So we have to move the legs and the hips while we feel the movement. Complex, right? A lot going on. So I'm gonna offer a couple techniques. We have 3 other proctors who do this well in the clinic frequently, so get advice, but the goal is still the same. Support the patient, passively move their joints. Everybody okay with that? Okay, what tends to work, sorry, if you could come over here so I could show. You'll see both ways, both using just the top leg to kind of control the lumbar moment and move into flexion. So I have this. A lot of people put the knee right into the hip crease. Go ahead and relax here, Alondra. Yep. And then bring the other hand back. And now Alondra has me flexing her lumbar spine by moving my body. Everybody see this? If the patient allows, if it's better for you, if it works, sometimes we do both legs. So try not to help me, actually. It's easier when, yeah, I know you're trying to help. So now I'm in here with both. I need to move her closer. Alondra, can you come just a little closer? Yeah, I know it feels like you're gonna fall. I won't let you. Good, so I like both because now I have her whole spine here. This is not okay, acceptable for everybody, so we need you to appreciate where you're at, what you can tolerate. We want you to practice both, but it is acceptable to use just one limb as you move them into flexion. Just like every movement, the first move might be very gentle, just kind of take them, how's that feel? You doing okay? And now we're gonna get into a little bit more segmental mobility. So first pass might just be to test the waters. Second pass is going to be to get in and start to isolate where we're at. Everybody good? We have our sacral base, L5, S1. We're gonna get right on to L5. So now Dr. Wolf's coming around and my middle finger is on S1 central spinous process that comes off that sacrum. My right hand now comes up into, what would that be, y'all? L5, absolutely. And now I move my body to create a little gap in the back. When I feel L5 move, I then can move up. L5, and now where am I going? Y'all are awesome, right? L4, and I can move a little more. L4, closed out, opened up, it's at its end. Now what am I going to? Y'all understand the theory? I remember deeply